Can you hear me? Can you hear me now? Good morning. We want to thank you guys for coming and inviting us to speak at your EMS education. My name is Christy Bucci. I am one of the clinical education specialists for St. Elizabeth Emergency Services. I've been here almost 17 years. And I have also been clinical adjunct for Northern Kentucky University with their nursing program for about 5 years.
And my name is Amy Daniels, also clinical education specialist for emergency services. I've been here for 8 years, and we are excited to talk to you guys today about report in the ED.
Yeah. So our presentation today is called Welcome to the WWED, when handoff feels more like a wrestling match. So this is our financial disclosure. We do not have a financial interest, arrangement, or affiliation with a commercial organization that may have a material interest in the subject matter of our presentation. These are the objectives of what we're going to cover this morning. We're going to define communication in healthcare, identify handoff distractions, describe consequences of communication breakdown, discuss strategies for good communication and handoff, implementation of a standardized handoff tool, and identify benefits of good interprofessional communication relating to patient outcomes. So this is just a fun little slide here of how we know you guys can be stressed out during your shifts, especially after leaving the busy ER. So just imagine yourselves sitting outside after you've been through the ER, the phones were ringing, alarms were dinging, patients are screaming, the nurses are on lunch, not paying attention, and EMS is distracted. Does this sound familiar to you all? Giving a report can feel like a constant push and pull until finally somebody delivers the final TKO statement that really sticks it to the other person. Through this interactive presentation, we hope to ease that tension during handoff by learning effective interprofessional communication techniques and the benefits of utilizing a standardized reporting tool for handoff.
If you guys have any questions, by the way, Tony is moderating the chat. Please pop in any questions that you may have, and then he will help us to answer your questions.
So these were a couple of questions Amy and I asked ourselves when we were discussing handoff. We know sometimes there are definitely some concerns on both sides, but we really wanted to look at how we can help with bridging that gap in the handoff process. So when you guys have been in the ER or when you were in school, do you currently use a standardized handoff tool? Or while you were in your paramedic program, did you ever receive any kind of education on a standardized handoff tool? So that's how this project came about that Amy and I started looking at when we were invited to the conference last year. What can we do to help bridge that gap? So with communication, I really like this quote, for by your words, you will be acquitted, and by your words, you will be condemned. We all know that words can be very impactful. How you use your words, the tone of those words that you use, and sometimes even the lack of those words can be detrimental to patient care and cause a lot of issues between the staff. So Merriam-Webster defines communication as a process where the information is exchanged between individuals through a common system of symbols, signs, or behaviors. So that basic communication skill is just not related to healthcare, but it's just in general through our lives. So that information should be clear when it's collected and translated. Poor communication is dangerous during patient handoffs, especially in the transport environment, because we know you guys give that information and then you leave the building and there's no way for that communication to continue on. It is also responsible for 12% of incidences involving patient safety when there are errors in that communication. And then how do we bring better patient outcomes? It's through that effective communication that will be at the heart of good patient care. So we have a fun video for you guys. We were super excited when we put this together. We wanted to extremely dramatize sometimes the interactions that go on in the ER. So when we made this video, we certainly dramatized it, but we all know after you guys watch this short clip that these are things that have gone on during handoff in the emergency department. So we had a lot of fun making this. We hope you guys enjoy the video. So what are you guys doing this weekend?
I don't know. I think we're gonna go out downtown and maybe come people and I'm gonna go to the.
That sounds fun. It's nice outside. I just
No.
can't wait to get out of here.
Excuse
I'm
me.
tired of being here
Me
too.
too.
Excuse me.
Can you hold on a second? Yeah, I'm tired of being here too.
I know. Fingers crossed the rain, so if that holds off.
Oh, hey, like sick patient here.
Hey,
Sick patient.
okay, take them over here.
I'm tired of being here.
I'm gonna nonstop.
Yeah. Don't get it. I just can't wait to get out of here. And doctor, do something fun.
Man, you should have seen the hole I pulled this one out of. Stuff was everywhere. Dog was barking. Annoying.
Okay, what are they here for?
Well, we got a call for chest pain, shortness of breath. And she was tripoding when we got there. Dude, the place reeked of smoke. I don't think I'll be able to get that out of my mustache.
Alright, did you guys do anything for them at all?
I mean, I tried an IV, but she said they usually use an ultrasound, so then I decided not to. But, you know.
Okay, alright, let's just move them over to the bed.
Alright, ready? One,
Yeah.
two.
Hey, can you just get over here? Just sit on the bed.
Here, can you go ahead and put this stuff on since you didn't do anything?
Can you bring the EKG machine in here? We'll probably
Alright,
do that
so
later.
she did say she was allergic to sulfa. You wanted to know that.
Okay, yep, we're good.
So,
Can you
but
go ahead and get out of my way so I can get this done?
sure. My pleasure.
Don't come back.
So we know that video is a lot of fun and we've gotten good laughs out of it, but really sitting back and reflecting on that video. We know you all have experienced some of those interactions like that in the emergency department with the exchange between nurses, maybe even the providers and the EMS folks. So we're truly trying to look at how can we make things better, not just for ourselves and building that trust and communication, but also for patient care. So what is a handoff? What should that look like when you guys are coming in? Handoff is defined as transfer and acceptance of patient care responsibility achieved through effective communication between medics and the healthcare providers. The information that you guys do provide include demographics, dynamics of the event, and treatment that was carried out. The American College of Physicians has called the handover as the most dangerous point in the patient's ED journey. The World Health Organization also identified communication during patient handover as a critical failure point that can cause serious breakdown in the continuity of care, inappropriate treatment, and potential harm to the patients. So it really does have a very impactful impact on the patient's care while in the emergency department if we are not communicating properly. So what is the purpose of communication? Why do we do it? Effective communication is meaning that we're not just saying words, that those words truly have meaning. Also, that transfer of care. When do we transfer care and accept professional responsibility? When does that responsibility for caring for the patient in between healthcare workers take place? We also, all aspects of the patient's diagnosis, treatment, or care is transferred to another person on a temporary or permanent basis. That communication should be effective, it should be efficient, and it should be appropriate because it does have implications for patient safety, continuity of care, and quality of care. But what does appropriate mean? Does appropriate mean the same thing to the EMS staff as it does the healthcare providers? Do we speak the same healthcare language when we are taking care of these folks? Do we have the same vision of what is appropriate for that communication? So during handoff, that is the EMS versus the hospital staff, whether again, it's the provider themselves coming in to take report from you guys, or it's the nursing staff themselves. Do we have the same priorities during handoff? We all know you guys are with a cardiac arrest, and the first question we ask is, did you get their name? Well, of course, in your world, you're just trying to get off the scene and get the patient to the emergency department as quickly as possible, or we're concerned about getting the name into Epic so we don't arrive the wrong patient. One of the other big pieces to this is 80% of EMS report no formal training in handoff. During our time in nursing school and when I've taught nursing programs, we focus on, we call it SBAR. We focus on that bedside handoff so that communication does occur, so that we're making sure that patients getting what they need from us. Also the expectations, what we expect from you or what you guys expect from us may not be the same. Are there any modifiable expectations within that we can do that will help with patient safety? We also want it to be brief. This handoff should take less than 60 seconds because you guys need to get back out in the field and we need to carry on with the patient care. The clarity of that information, definitely medications and treatment. When you guys are coming in, we don't want to duplicate something you did out in the field. We don't want to end up overdosing the patient on a medication because that exchange did not happen. There's also reports that EMS believe that the message they're trying to deliver is not heard by the emergency medical staff because we're not fully listening. So that does cause trust issues. And then when does that transfer of responsibility occur? EMS have a different vision than what our medical staff have of when that truly happens. Is there a legal aspect to when that transfer of care happens? So it's unclear when that does occur. Does that occur when the patient leaves your stretcher and arrives to ours? Does that occur when you guys hit our doors? Does that occur when the physician comes in and takes over the patient's care? So those questions are still kind of up for debate of when that truly does happen. Lastly, can we just all get along? What can we do to build these interprofessional relationships? We all know there's sometimes a lack of respect for one another and our roles in the healthcare field, but those problems with interpersonal relationships and trust between the various service workers sometimes are linked to different ideas of priority that can nonetheless undermine an efficient handover. Medics have reported feeling degrading from the negative attitudes and the tensions, which then affects the quality of care that is being delivered for the patient. Then when the patients are watching this exchange between the EMS and the nurses, do they now start having trust issues with, am I going to be well taken care of here, or am I coming into a hostile environment? What is their perception of how this goes? 20% of the time EMS crews report that they do feel unheard, that the medical staff is not listening, so why bother? Also, 9% of the time, medics have reported that they have to repeat what they are saying. When we know that's true, I'm guilty of it myself. When you guys have told me the blood sugar and I have to ask again, I'm so sorry, what was the blood sugar again? Even though you'd already told me. Those things can lead to a miscommunication, which the Joint Commission reported that 80% of serious medical errors involved miscommunication between providers during patient transfers of care and handoffs, leading to delays in treatment, which also increases the length of stays.
So interruptions. I don't know if I've ever taken or even given a report without interruptions. The ER, generally speaking, is a chaotic environment. Adding the holds on top of it, patient interjections, hallway patients, it's the wild, wild west out there right now. So interruptions can cause the patient to feel that they are being dismissed or they're not as important, or their case is perhaps less interesting. So it kind of all circles back to the patient and their perception, and we want them to feel that they're being taken care of, and we've got this, we've got each other. So some things that we can do and things that we can change to minimize interruptions. The noise level in the ER sometimes is kind of just insane. I know we're kind of continually overstimulated by all the dinging and the ringing and the screaming and, but some things we can do to help tone that down is maybe on our way in or once you all have come into the room, we can close the door. I'm a big door closer. That way we can really focus on what's going on in the room, the report being given, and the patient at hand. Another thing is maybe if it's safe to, I know you all communicate using your radios, so just turn down the radio just a smidge so it's not screaming. That's a modifiable interruption that we can reduce to help with that. So another thing is interruptions and clarification questions by staff. So, and that's kind of on our end too, creating a team that comes in instead of, I come into the room, I arrive the patient, but it's Christy's room. So she comes back in and she says, oh, hey, wait a minute. What did you just say? what was that blood sugar? So, we take accountability for that as well on our end. But if we can create a team and then we're all there and we can begin the report and just go start to finish. Providing excessive details. So I swirls out. It's just me. I think a lot of us do as well. When the story gets too long, I start getting lost. So just making sure that we're staying organized and we're hitting the hot points first. And that goes into the organization. And then lack of knowledge regarding the patient. So the driver probably shouldn't be the one giving a report on the patient. They weren't the one in the back with doing the interventions and whatnot. So, and then time restraints, of course. You might get a call for a full arrest while you just dropped off a shortness of breath. And you're like, they're breathing. They have a pulse. They're fine. Bye. You might have to do that sometimes. But again, trying to be cognizant of those time restraints and being respectful. So another thing is transferring the patient during report. That happens a lot. I mean, I think it happens 99% of the time. Like I said, we're all multitasking. I'm a big multitasker. So, we're pulling that patient over. You're giving me the details. You're giving me the lowdown. But really, for patient safety, we shouldn't be transferring the patient during report. So maybe transfer the patient first, and then we can focus on report. By doing this, we're focusing on the patient and their safety. We're making their safety a priority, because if we're not focusing on the patient, then, we just parked the cot, we locked it, and the patient gets up and walks to the stretcher. Well, before they get to the stretcher, they tip you over and pour out. And that's a problem. So making sure that we're all there and we're all hands-on to the patient and assisting them to get to where they need to be safely. Some unmodifiable things, obviously there's language barriers. We live in a very diverse community. So I know y'all don't have the iPads in the field or translators in the field, although I hear that you're working on that, so cool beans. But that's difficult. So when it comes to that, just giving us the details that you can of the transfer and care, or of the transport and what you did for the patient, doing the best you can there until we can get the iPads going in the department. Environmental distractions. All right, we already touched on that. It's cuckoo for Cocoa Puffs around there. We can do our best by closing the doors and trying to, tone down the noise in the department so we can get good report. Something we also can't fix: patient volume, attitude, education, or lack thereof, and respect or lack thereof. It is very difficult to give report over top of a screaming patient. So I don't know, sometimes if we can just get them to the bed, have someone in there watching the patient safely, and then we'll step outside and receive report. Sometimes that's just for the best, as long as it's appropriate and safe for the patient, of course. And then heavy workloads and high stress, can't fix that right now. That's every ER right now. You all have seen the halls lined with patients and squads backed up, and you guys have been waiting for beds, and that's unfortunate as well, but it's the nature of the beast right now. So we're trying to modify things on our end, but it is what it is right now. So incomplete handoff. So when all the pertinent information is not relayed, it can cause delays in medical treatment, inappropriate treatment, and even sometimes duplicate treatment. So if you want to refer to the chart on the left, this chart depicts what % of data is relayed in a report or handoff. So the one that's most concerning to me is the medications and allergies. So less than 10% of meds and less than 10% of allergies are relayed. It's kind of a big deal because first of all, I'm not saying I want you to get the med rec that is this long and go down and say they took their metoprolol at 10:55 this morning. Okay, not expecting that, all right, because they have books of meds. But just some pertinent medications, if they came in for shortness of breath and they took their inhalers before they came, just kind of stuff like that. Allergies are a big deal. Sometimes, depending on the situation, we don't always have a chance to get them arrived in Epic before we have to start intervening. So if you come armed with that information, that is super helpful to us and it can result in not having a patient harm. So with incomplete handoff, it can lead to increased stay just because of information not received. And then handoff, the quality and the length or brevity of the handoff is impacted by the years of experience. So a brand new, or not even a student, they just maybe graduated, is going to give handoff differently than someone who is more tenured. Or maybe they go, A to Z, like boom, they hit all the points. It's a super long report, but it's very detailed. Whereas, I'm more tenured and I'm like, they're short of breath, their vitals are stable. Yeah. But also, so on the flip side of that, the nurse receiving report based on their years of experience, they're going to receive that differently. Some nurses are new. And if you say short of breath, vitals are stable, they're going to be like, what else? I don't know.
Yeah.
They're going to panic. So they're probably going to want a little more information than that. Also with that, when I tell Christy vitals are stable, that can mean something totally different. Because I know for a fact that if I called upstairs to give a report and I'm like, hey, yeah, blood pressure's good. They're fine. And their blood pressure is 155 over 80. They're going to go back and look at that and they're going to freak out. And they're going to call me back and say, you need to address that blood pressure. That is not a good blood pressure. Where in ER land, we're like, man, that's good to me. They're good. So it's just, knowing your audience and knowing what's normal, what's not normal could be different just depending on who you're talking to. So strategies for effective communication, eye contact. And yes, this goes both ways, okay? Because I don't know how many times you all are giving a report and we're like, and we're arriving them in Epic, all right? That's distracting. And that's not giving full attention to the details. And they're too busy doing one of these and they're not actively listening. And they're like, what was that blood sugar again? And you're like, Lord have mercy if I have to say it one more time. But I know I'm bad about that. I'm sorry. And like I said, this does go both ways, all right? So giving a brief and concise report, making sure you're hitting the highlights and not stretching out too long so my squirrel brain can focus. Maintaining a respectful dialogue goes both ways again. Collaboration and teamwork obviously is going to improve and it will show when we are being good active listeners and being a good team. So feedback. So I know there's been a study and it's shown, which I think you probably agree with us, that EMS providers appreciate feedback on interventions. So, saying you gave Solumedrol en route for this COPD exacerbation and serial breathing treatments, as many as you could in the way between, and you dropped a line and, be like, hey, that's great. That's really helpful. That helps to expedite this patient's care and we can see the results of the interventions and we can move forward with their care more quickly and get them to their end destination, which is going to be in the hallway boarding. But hey, we can at least get the ball rolling to get them admitted and get them where they need to be. It'll affect our throughput. So we do appreciate that. I'm sure you would like to hear the feedback on that as well. Managing the environment, we already kind of touched on that with the turning down the radios, closing the doors, and that kind of stuff. And then ensuring the ABC. So when we're giving handoff, make sure you hit airway, breathing, circulation. The three main things that's going to kill them first. And that would help us to eliminate any sort of emergent condition. So let's talk about a standardized reporting tool. So firstly, the benefits of it. The information is concise, it's organized, it's brief, focused, it enhances teamwork, and it provides a definitive transition of the responsibility of care. So that once I get to this point, my hands are clean. Here's your patient, ma'am. Take care of it, okay? I worked really hard on that one. So it also decreases repetitive questions and information. So if Christy comes in with the patient, she's my EMS person, and I know that this is how she gives a report. She is going to start with A and she is going to end with Z, and all these questions in my brain are going to get answered in the process. I'm not going to interrupt her and be like, what was that, sugar? So I know she's going to get to that point. So that will help to reduce that distraction. So just for an example, the chart, this is just an example of a standardized reporting tool on the right-hand side chart. So chief complaint, history, assessment, RX translates to treatments, and then transports. So what does that mean exactly? A little more expanded here. So chief complaint, all right, what was the call for? What were you guys called for? And sometimes that evolves. Like, you get called for a toe injury, but meanwhile they're sitting here blue and you're like, well, that just escalated. So it can change. We do understand that. And then history. So what's their medical background? Again, you don't have to say like, you know, they got a call for shortness of breath. You don't have to say, well, they broke their toe in 2004 and had a hernia repair. Okay, nope, don't need to know that. Just like pertinent medical background, existing conditions, medications, again, not their binder full of meds, just what's pertinent. If you can get that information, even sometimes you can even get that information. So sometimes these people are altered and that's just not happening. We can barely get their name. And then their allergies. I already hit on the importance of that. So the assessment piece, so your physical exam, the breath sounds that you were able to hear, the heart sounds that hopefully you were able to hear in the back of a squad. Vital signs, again, not just saying vitals are stable. Stable to me is different than stable to her. So I'm a little more relaxed probably on some of the vitals than say the floor is. And you all might be a little more relaxed on vitals than we are. So we don't get excited very easily sometimes. And then any visible injuries in that assessment. So what do we got to address? Are they bleeding? Are they cut? What kind of boo-boo do they have today? And then treatment. So what'd you do? But we would say that nicer, of course. So what medical interventions did you do? Did you give Solumedrol? That one's huge. If you know you didn't relay that to us, then we would go ahead and give them another dose if they were a COPD exacerbation, and then we just double dose their Solumedrol, which is not great for the patient. Pain management. What'd you give them en route? Did it work? Did it not work? Did you even have time to figure out if it worked because you were 2 minutes down the road? And of course, any life-saving interventions. Did you cardiovert them? Did you give adenosine? You know, those kinds of things are pretty important, obviously. And then transport. So details and time of the transport. What happened en route? And then were there any changes in condition? So, you know, sometimes knowing what their environment was before they came in is helpful for us to know what's going on with them here. And also some details, knowing if they have bugs, that's a huge one. We would love to know that. The heads up if they got the BBs is great always. But also if they had any changes. So, you know, if they declined or if things improved after that nitro, or, you know, they spontaneously improved once they got in the back of your squad, that's always a beautiful thing. All right, so we just talked about a standardized reporting tool. So we made you all another video. I know you're super excited about this one. So this one demonstrates the use of the chart tool that we have just explained to you and how perhaps it would work and be a more effective communication tool during handoff. So you did it. I didn't do it.
Where are you going this weekend?
I don't know, I think we're gonna go out downtown, there's that concert going on.
Hey guys.
Hey, how are you guys?
Hey, good. Got a meeting for you.
Okay. Hi, my name's Drake, thanks for choosing General Hospital. What's going on today?
I'm having some chest pain. I'm feeling pretty short of breath.
Okay, let's get you over here to the bed, okay? You mind taking her over there?
Yeah, absolutely.
You wanna try and move her over?
I think she can scoot over. She did pretty good at the house.
Do you feel like you can move over here? Okay, I'll take your purse here. What do you got for a report?
Let me turn my radio down to avoid distractions.
Thank you.
All right, so I have 97-year-old female Janice Huff, complaint of chest pain, shortness of breath. Had a recent MI with stent placement. So she also is a 2-pack per day smoker.
Okay.
And she's on 2 liters of oxygen at home. So blood pressure is 158/76. O2 is 87% on 2 liters. Heart rate's 110, respirators 32. She's afebrile at 98.6. Blood sugar is 98. This is her 12 lead.
Thank you.
So we did get a left 20 in the left AC. So I went ahead and gave her 1 nitro for the chest pain she's complaining of. She said it's about an 8 out of 10. No relief there. Did also give her a breathing treatment en route. She's diminished bilaterally and has a little bit of crackles going on. So gave her breathing treatment. So we're still waiting to see the effects of that. At home, she was tripoding. So we did transport her in an upright position for comfort.
Okay.
And we did use lights and sirens, given that she just had an MI with stent placement.
All right, sounds good. Thank you, I appreciate it.
Yeah.
We'll take it from here.
Yep, have a good day.
Thanks, you too. Be safe.
Will do.
How are you feeling today?
My chest is really hurting.
Okay, we'll get you taken care of, all right?
Thank you.
All right. So besides me saying diminished, that was a pretty good handoff. It was short, it was concise, the interruptions were minimized. The EMS personnel got to speak freely without interruptions. We had an active listener, eye contact, and the patient was there and was able to hear the exchange. So good things. All right, so bringing it all back. So with everything we do, we always got to bring it back to the patient. Remember your why. We all get in this field for a variety of reasons. I don't think any of us are in it for the big fat paycheck because I don't know about you, I don't get paid the big bucks to do this. But we do it because something's called us to this profession, and it's all about the patients at the end of the day. If we can touch a patient anyway, if we can help them and make things better for them that day, that's always a good thing. And we just have to remember, the patient's at the center of everything we do. And sometimes that is hard because when they call you all or when they present to the ED, they are there because it is their perception that whatever they have going on is an emergency. And they have a lot of anxiety and they're upset and they're terrified. So we just kind of have to dial that back and remember, that this is in their perception, one of the worst days of their lives. So it's it's always beneficial to try to remember that, even though it can be very difficult when they're giving you the what for and saying very not nice things to us. So, but by doing all this, we provide safer outcomes, decrease errors and report, and provide a good continuity of care. So, we provide that A to Z report, and we've got a really good grasp on what happened before they got here. And we can move forward immediately with the care. We're not second guessing things. We're not questioning, oh man, I should have asked them that, but they're gone now. I don't know what happened. And that would have been useful to know. It's a seamless transition and we're moving forward from where you all started. You all gave us a good start. So some key takeaways here. So effective communication brings better patient outcomes. Incorporating a structured tool will keep the information organized, brief, and professional. It also creates a culture of respect by limiting distractions and interruptions. So, because I know that you're going to start at A and end at Z, I can zip my lips and hang tight because I know you're going to get there. It optimizes team dynamics. It really pulls us together and looks like we're working as a team. We're providing that respectful interaction between us, and the patients see that. They see everything. Sometimes we kind of take that out of our brains. We not forget them almost, but you roll up, the cot's behind you, you start talking, and I'm asking you what their name, date of birth is, but I should be asking the patient. She's alert, she knows. So instead of, it's some little modifications that we can do to really refine this process and make it a really seamless transition of care for these patients. So, and that's the other thing too, is providing that seamless transition of care. You're not waiting around like, do they need me? Do I need to say something else? It's like, no, start at A, ended at Z, I'm out of here, going on to the next run. So, okay, so we breezed through that. We're gonna give you some time back here. Before we do questions, if you all don't mind, while you're hanging out, can you scan this QR code? We have a little survey. We are actively working on a project, and we would really appreciate your feedback on this presentation. No matter what you say, I'm not taking the mustache off in the video, sorry. But if you don't mind, we are always open if you have improvement suggestions, feedback, we're open to anything. So if you don't mind providing the feedback, we would really appreciate it. So what questions do you have for us? Bring it on. Tony's got the chat if you want to chat, or you can just interject, knock yourself out. What you got for us? I know y'all want to know where I got the mustache. It was Amazon, by the way. I know, I can't, maybe I need to do, like, take some testosterone and really get it growing in. It's not as good as Tony's.
The manscape.
Yeah. Nothing. No little dots going on in the chat. All right, so we have to give credit to our cast and crew. So we appreciate everybody that helped us make the videos possible. So. Great. Well, thank you all for taking time today to listen to our presentation. We do appreciate it, and we really do appreciate your feedback. Did you put the survey link in the chat? Okay, Tony did put the survey link in the chat. It is anonymous, so feel free to light it up, whatever you want to do. But we appreciate you guys as always, and we hope to make the recording a little
Yes, a
better
little better.
between us. Yeah.
And we are working on it on our end also.
Yep.
But
We understand there's opportunities.
Yeah, we understand our opportunities also.
So.
Trying to work with some technology.
Yep. Yeah, working with technology, the Pulsera, trying to streamline processes and make sure that we're utilizing our technology to its maximum to make this transition seamless for everybody. So
We welcome that in the feedback also. When you guys are answering the survey, if you have suggestions, even with the technology piece of it, we are happy to see what we can do about those things. We can't address everything overnight, but we are, again, we're a team. We want that team building. We are all here for the same common cause. So we do appreciate that feedback if you do have it.
Yep. And you can always reach out to myself or Christy for any comments, questions, concerns moving forward. So, but we appreciate your time today. Y'all stay safe out there and have a good day.
Thank you.